wherein I thought it was very interesting to understand the concealment and blinding. I liked the way he explained it, giving examples. He also brought out a few important points, particularly the spirit. Am I audible, Dr. Chandramohan?
Yes, yes, we can hear
Yes,
you.
sir, you are audible, sir.
Yeah, yeah.
You are
So
audible, sir.
Dr. Dennis also talked about the spirit guidelines. He also mentioned that just very recently there are a few guidelines. There has been an amendment in the spirit guidelines which he urged everybody to go through. There is a 2 point checklist which we need to go through while submitting our randomized control trials. In the fag end of the talk, he also mentioned something about how we should interpret the hazard ratios in a very interactive way. What does that particular thing mean? I found it very interesting that he brought out the IROC study. Interestingly, the IROC study actually it brings an contrarian view wherein actually it mentions that whenever we are doing an intracorporeal diversion, actually robotic approach versus the open approach, it really doesn't make a difference. And such an important finding, we can understand, interpret it, and understand the nuances only and only if we understand the statistics of the whole thing. I really look forward to the second part of this talk, wherein is going to talk about the superiority and inferiority complexes. And I look forward to the talk by Dr. Dennis. Thank you so much, sir.
Thank you, Dr. Arvind. So nicely, very elegantly recapped. Let me go back to my friend, Dr. Satya Narayana. So what were the highlights for you, Satya, yesterday? For you, what were the highlights?
Sir, yesterday it was from the randomized control study. What is randomization? The definition. Then what is the purpose of randomization? Yesterday only first time I saw what is the purpose of randomization, like everything, age and everything, because of the huge number of the volume of the sample. Then only we can achieve the randomization. At that point, I understood. Then relative risk. Then what is allocation concealment and what is blinding. Then types of blinding we discuss. Then this one experimental and experiment control event rate, and then experimental event rate. Then how to calculate relative risk reduction, relative risk ratio, and all those things. In last point, hazard ratio, I was a bit confused, but after the class, then I just Google something, then I little bit I understood. When the hazard ratio is 1, then there is no difference. When it is less, then there is some benefit. When it is more than 1, there is some problem with the one part of the study. Then I understood, but still the survival analysis is little bit confusing for me, sir. Then I have to little bit know about more about the survival analysis.
Right, Dr. Satya, thank you for that. We're going to do one whole session on survival analysis. It will be the last session during our statistics session, so you'll get a little more clarity there. But you're right. See, in a ratio, I mean, if you go back to not even high school, if you go back to primary school itself, if the numerator and denominator are the same, you get 1 in a ratio. Anything that is less than 1 means it is of benefit. If it is more than 1, right, means harm. Simple as that. Yesterday, a little bit I told you on how to interpret that. And Tanmay, who has attended my session earlier, he knows also because in a statistics session I had explained what is confidence interval and how to interpret that confidence interval also I shared. And you may recall when we computed the odds ratio for a case control study, I explained also how we get the 95% confidence interval. So in all of those 4 cells, A, B, C, and D, it is the square root of the reciprocals.
1 by A plus 1 by B plus 1 by C plus
correct.
1.
Yeah. You remember that. Sorry, just give me 1 second. There's an unusual phone call. 1 second, please. Sorry. Sorry, some miscommunication, and I'm supposed to do another call. Anyway, sorry about that. Yes, Satya, you were telling about the confidence interval, 95%, and how to compute that.
Yes, sir. If we see the odds ratio, it will lie in the confidence interval between, if it is 1.5, the 3.5, the odds ratio will be 2.5. It will lie between the confidence interval. That is what, but still I have some confusions regarding confidence intervals.
I think I told yesterday. Sorry, I don't recall whether I told this group or someone else. If you are confused means you listened,
Yes, yes.
you understood a little bit. So it's a good place to be.
Okay.
Right? So being confused is a good place to be, rather than the opposite is blissful ignorance. You know, before this you were not confused about confidence interval, right? So
I
it's a
don't.
good place. It's a good start. Being confused is a good start. Okay. So yesterday we did all of this, and today we'll go into other research designs, and we will start. And I requested Dr. Chandramohan to put all the subtopics on today's session in the flyer, and he kindly did that. So let me share my slides and we will get started. Okay. So what do we do if we cannot use a placebo? Okay. So there are situations where we cannot use a placebo. Right? That means there is already a treatment available for this condition. So we have to compare the new treatment with the best available treatment. Okay, so so what are the options for that? So that's what we're going to look at. So we have to do a trial. It's not a placebo-controlled trial now. It is called an active control trial. Now, when it is an active controlled trial, we have the following options. Okay, give me a second. Sorry. Okay. So when a placebo-controlled trial is either not feasible or not ethical, as I told you, we need to do an active control trial. We compare it with the best available treatment at the time. Then you're going to show that your treatment is better than the best available treatment. Okay. So now the analysis and the approach for this is different. So I'll give you the key concepts, then we'll take it from there. Okay, now if you are very confident that your new treatment is better than the best available treatment or the trial or the standard treatment, then you will design a trial to prove superiority. I'm going to prove superiority. Now, if not, you're going to design a trial to prove that your new treatment is not inferior. Okay, this took me 3 months to understand. Okay, so if you're more confused than what you were before this, it's a good place to be. Okay, so I will do my best. I have taught this 80, 100 times to different people, including undergraduate students too. So I will be slow and clear, but it takes us a while to understand it. Okay, so we're going to design a trial to say my treatment is not worse off than the standard treatment, and therefore it is called a non-inferiority design, or even better, it's called a non-inferiority hypothesis. So we'll call it a design to keep it simple. Okay, so we have the following question: is the new treatment better than established treatment, or is it not inferior to the established treatment? We're going to use the word established treatment. Another word for established treatment is the best available treatment. Okay, so we have 3 design options here. For these 2 questions, there are 3 design options. If you believe that your new treatment is better than the available treatment, you're going to design a treatment to say superiority. Then I told you about non-inferiority. I told you that a moment ago. Now we have another option. We have another option which is called equivalence. Okay, and I will explain this with a diagram now. With a can we mute the other lines, please? There are some lines open. Okay, thank you. Yeah.
Muted.
Yeah, thank you. Thank you for that. Okay, so I'm going to show you a simple diagram and I'll explain it step by step. This diagram I drew in 2005 or 2006. Yeah, almost 20 years ago. That was for my master's thesis. And it is adapted from a book by Dave Sackett on clinical epidemiology, and I'll explain it step by step. Okay, so here is that diagram. Now, what do we see? We see one bold vertical line. There is a bold vertical line in the middle. All right. Now, this is the standard to judge benefit and harm. Okay. Now, there are two dotted lines on either side. Okay. This is the line of superiority, and this is the line of inferiority. All right. Now, what else do we have? We have three vertical lines. Then we have 5 horizontal lines of different sizes, and both of them have arrows at the end of it. Now, when we do a trial, we get a treatment effect. Treatment effect is a relative risk reduction or a hazard ratio, whatever it is. And you get the 95% confidence interval around it. So the horizontal line, the middle of the horizontal line is the treatment effect, and on either side is the 95% confidence interval. Okay, are we all clear? All right. So a couple of things more. We have the superiority margin here, line here. Okay, left of it, if you get your treatment effect left of it, means that the new treatment is superior to the available treatment. Let's go to the opposite side. We have a line of inferiority, and if your treatment effect falls to the right of the inferiority line, means that the new treatment is inferior. That side is superior, this side is inferior. Okay, step by step we'll take it. Now, we have option A. What is option A? Option A lies completely within the line of superiority and inferiority. That means this treatment is equivalent. It's exactly the same as your old treatment, or the established treatment that we already have is exactly the same. That means it is equivalent. A means it's equivalent. Now, you may have heard bioequivalent studies that pharmaceutical companies conduct. Please don't confuse yourself with that, because bioequivalence is blood levels of one drug versus another drug. Here it is treatment effect, either mortality or whatever else. So this is a rare occurrence. It does not occur. So just for theory, does not occur in the sense to, and by the way, I have drawn this line on either side nice and wide so that we can see it well. But actually this line of superiority and inferiority is quite narrow. It's quite narrow, quite small. Okay. To get your treatment effect in the middle there, and is 95% confidence interval on either side also within that line, is difficult. Okay, so let us not worry about it. Now, what do you think outcome B is? What do you think outcome B is? It is to the right of the line of inferiority, correct?
Yes. It's a more
That means-
inferior study. It's a more inferior than the existing one.
Okay, the new drug that you tried out is clearly inferior. Okay, the confidence interval is not overlapping. See, for two lines, two other horizontal lines, C and D, there is a bit of an overlap. Okay, so treatment B is clearly non-inferior. We have to be happy that we got a clear result and we are not bothered. We're not going to use this treatment. Let's go do other research and find out. Okay, now what is treatment C? Treatment C, right, is crossing the line of inferiority. It is here, it is not crossing the line of superiority. Still, there is some gap here. Okay, now this is an unfortunate kind of a result. It is non or indeterminate. That's what the experts call it. It's indeterminate for non-inferiority. Okay, now let us jump from there. That means it is neither superior nor is it not inferior. Got it? Neither superior nor non-inferior. That's what we wanted to prove. If it is not inferior, that means it is similar to the previous drug, then I can use it. Let us skip D for the moment and come to E. What do you think E is?
E is more superior than the existing treatment.
You don't have to say more or less, it is superior.
Superior. Okay.
Superior to established treatment. So we need to start using this drug. It is clearly superior. Now, what is D now? D is within the line of inferiority. Can you see this? Can you see this? Okay. And it is still here. It is not clearly on that side like E. It is not superior, firstly. But since it is within this line, and there is this gap over here, it is non-inferior. Now, if this drug D, if its adverse effect profile is favorable, it is similar, and the regimen is slightly better, we can start using this. Usually, new drugs are a little more expensive than the older drug. Is the cost worth it is what clinicians have to think about and use it. Now, in oncology, you will see a lot of non-inferiority trials. Okay. So if you go look at your urology journals, I don't have an example today, you will find non-inferiority trials. This is what the concept is. E is clearly inferior. We have to definitely start using this. Even if it is a little more expensive, it is worth it because it's clearly better. On the other hand, D is not worse off than the previous drug. If the regimen is okay, if the cost is not just too much and adverse effect profile is all right, we can start using it. Okay. So this is when we cannot use a placebo. All right. So let me give you an example. I'm sure you all are familiar with this new oral anticoagulant. You may have used it in some of your patients, particularly for DVT. I mean, surgeons use it for DVT. Okay. And at that time, when we did the study at that time, warfarin was the drug of choice. All right. And then when this new drug came, we were not very sure. We were not very sure whether it would be superior. So we said, let's design a trial for non-inferiority. And then we were also not sure about the dose to use. So we tried out 2 different doses as well. So here are the results. I'll go straight away to the results. So firstly, we had 6,000, 6,000, 6,000. So 18,100 odd patients. Okay. We used 110 milligrams dabigatran in one arm, 150 milligrams dabigatran in one arm, and warfarin. And as you know, warfarin's dosage is based on INR. We don't have a specific dose. Outcome is stroke or systemic embolism. Oh, I forgot to tell you that these patients had atrial fibrillation. They have atrial fibrillation and there are thrombi sitting in the atria, and then they can get dislodged and then they can go and cause an ischemic stroke or even a systemic embolism. Okay, so this is what we did. And so since we were not sure about the dose, we tried, we said, let's try out these 2 doses compared to warfarin. Okay, so 182 patients in the 110 milligrams had a stroke or systemic embolism. 134 people in 150 milligrams had a stroke or systemic embolism, and 199 people in warfarin arm had stroke or systemic embolism. So which of the 3 drugs is good now? Okay, to make it easier, you have you have a percentage per year. So in other words, 1.5% per year, 1.11% per year, and here 1.7% per year. So clearly 1.1% is the least, correct? It is the least. So 150 milligrams is the best dose now, okay, as we see crudely. Now, this is a non-inferiority trial. So we have to do the non-inferiority comparison, and that is there in the next slide here. Okay, so here we looked at relative risk. Now you know how to read relative risk, correct? So 110 milligrams, 110 milligrams relative risk reduction of 9%, 9%, not statistically significant. Therefore, 110 milligrams, oh, by the way, this is, so our comparison is dabigatran versus, let me go back here. So we had we had three comparisons, 110 versus warfarin, 150 versus warfarin. We also compared 110 with 150. Three comparisons, all right? So here is it. Let's scratch out this line. 110 versus warfarin, there's only a 9% reduction in stroke or systemic embolism with dabigatran compared to warfarin. So it is not superior. As you see, the confidence interval is crossing 1. However, it is non-inferior. So you see the p-value for non-inferiority is 0.001. P-value for superiority is 0.34. This one, okay? This is how to interpret it. Now let's look at this other one. Dabigatran 150 versus warfarin. There is a what percentage reduction, Satya?
So 66% of risk reduction.
No.
34.
34% reduction.
Okay.
Okay, so you see, at least you are still a postgraduate resident. When I was faculty, I still was wondering where is 34 till I went to learn it. Okay, you are all lucky you're learning it now only. I searched all over the slide. Where is 34? I can't see 34. Where is this man telling 34% reduction? Now we know. Okay, so 66 means 34% reduction, and the confidence interval does not cross 1. That means this 34% is a statistically significant reduction, and it is superior. 150 is superior. So both non-inferiority and superiority. Clearly, if it is superior, you don't have to worry about non-inferiority. Okay. Then we had one final comparison, which is dabigatran 150 versus 110. There was a what percentage reduction here?
27.
27% reduction. You got it? 27% reduction. Here is your p-value, 0.005. Does not cross 1, statistically significant. So conclusion is 150 milligrams, hold on. Okay, we can say 150 milligrams dabigatran is superior to warfarin, and 110 milligrams is non-inferior to warfarin. So now we have two doses, both we can use. So if we are a little bit concerned with bleeding in a patient, we can use 110. If you're not so concerned about bleeding, we can use 150. So this is the conclusion. Now, as you know, New England Journal is a general medical journal. So this is how we conclude. In conclusion, we compare two doses of dabigatran with warfarin. As compared with warfarin, 110 milligrams was associated with similar rates of stroke. Here we don't want to confuse people and say non-inferior, etc. Okay, general physicians will be reading this. Okay, associated with similar rates of stroke and systemic embolism, and 150 milligrams of dabigatran was associated with lower rates of stroke. Here we are saying similar, here we are saying lower. That means this is superior. Got it? So this is how we interpret this. Okay, let's move on. I have another question. Can we be more efficient with trials? Can I do 2 or more treatments? Can I evaluate in 1 RCT? Okay, okay, then can I study the interaction of these two? And will it be efficient in terms of cost and time is what we're looking at. So for that, we do the factorial design. And here, okay, let's move on. Let me give an example of another study that we were involved in. So middle-aged to elderly patients come to hospital with hypertension and dyslipidemia or hypercholesterolemia, correct? Together they come. Now, at that time when we designed this was published in 2016, but we were designing this, I remember it very clearly. It was in July 2015. And a few days before that, I had moved to Canada. So I remember this is the first major meeting I attended. And we were a group of people from 24 countries that did this study. Okay, so when patients at that time, people with moderate blood pressure and moderate level of cholesterol rise were not given blood pressure lowering treatment and cholesterol lowering treatment because there was no evidence. So we said, let us do this and let us do it in an efficient manner. And when we lower both, this should overall reduce the risk of cardiovascular events. It is not just reducing lipids and reducing blood pressure. over a period of time, does it reduce stroke? Does it reduce MI? Does it reduce death? Does it reduce cardiac arrest? That's what we want to look at. Okay. So we chose angiotensin receptor blocker, candesartan hydrochlorothiazide. Candesartan and hydrochlorothiazide, 2 different drugs, and compare with placebo. And so this is for blood pressure. Then the other side, we had rosuvastatin, which is quite a potent statin, and comparing it with placebo. Now, what are the options we have now? There are 4 different options. Just like you remember the odds ratio that we calculated in case control design or even in a cohort study, when you're looking at interactions between two, it will fall nicely into a 2x2 table. Otherwise, it's also called known as a contingency table. Okay, what will come in this arm? Here, there are 4, it's not really 4 arms, 4 cells we call it. What will come here? What will these patients get?
Usually responding to the treatment. Those who got responded are exposed or diseased.
No. Okay, now we are doing a trial now. Okay, so here they will get both of these treatments. They'll get candesartan and rosuvastatin here, both. Okay, here they get only rosuvastatin and they get a placebo. I will show you another diagram. Here they get placebo and candesartan. Here they get placebo and placebo. Okay, so let's look at it now. So here, rosuvastatin and candesartan. Okay, here rosuvastatin and placebo, candesartan and placebo, here placebo and placebo. Right? So we have 4 different ways, 4 different options now. So this is called a 2 into 2 factorial design. We can have a 2 into 3 factorial design. We can have a 2 into 2 into 3 factorial, but I'll keep it simple. We'll just do the 2x2 factorial design. And many oncology studies have used this design. So now if you read this in journal articles, you'll be a little more clearer. How do I analyze it? So let's go back here. I can compare, I want to know the effect of one drug versus the other. I can compare this with this, correct? Rosuvastatin versus placebo. If I want to compare candesartan versus placebo, I can compare this and this. If I want to compare the combination of these 2 drugs, if I want to, the combination, both drugs are here versus placebo, I can compare. So I can do a 3-way comparison here of effect of one drug versus no drug, another drug versus no drug, and both drugs versus no drug. I can do all of this. So this is a 2x2 factorial design. However, this approach, so this is called analyzing each cell separately. What I just showed you is analyzing each cell separately. It is a correct analysis, but it's an inefficient analysis. It's a correct analysis, but an inefficient analysis. So what do? We better analyze both the cells simultaneously. And it is called analysis along the margin. Okay. And let me show you how this works. So a simpler diagram here. Remember, this is candesartan and rosuvastatin together, right? And this is rosuvastatin alone. This is candesartan alone. Now, the previous analysis approach was like this. Okay, it is not so efficient. Now look at the analysis along the margin. Now, this is all the patients who got rosuvastatin. All rosuvastatin, correct? Versus all who did not get rosuvastatin. Got it? So if we go back here now, let's assume this is 5,000 patients each. Okay, 5,000, 5,000, so totally 20,000. In effect, this was 12,900 odd patients, but for simplicity, we'll take it as 5,000 each. So 20,000 patients. So if I do this comparison, I have 5,000 here, I have 5,000 here. What is my sample size? It's only 10,000. Any way I do, my sample size is only 10,000. But how many patients do we have in the trial? We have 20,000 patients in the trial. Correct? So all rosuvastatin is how many now? 5,000 plus 5,000. Correct? 10,000. All not rosuvastatin is how many now? 5,000 plus 5,000, 10,000. So when I analyze it like this, I'm using all the patients in the trial, and this is a much more efficient analysis. Now, is there another analysis? Now we have rosuvastatin versus no rosuvastatin. Similarly, we have all candesartans here, all candesartan versus no candesartan. Again, 10,000 and 10,000, 20,000 patients. So this is called analysis along the margins, and it is very efficient. Okay, let's look at the results of this trial. So this trial, as I told you, had about 12,000 patients, 3,200, 3,200, 3,200, 3,200. So candesartan plus rosuvastatin, both the drugs, rosuvastatin alone, candesartan alone, placebo alone. Okay. So the primary outcome is, look at this, death, MI, stroke, important outcomes. Okay. So now hazard ratio here is 0.71. What is the percentage reduction? 29%. After some time, you will get very good at it. It'll take a little bit of time to minus two numbers from one and multiply that by 100. It'll come very quickly afterwards. And is it statistically significant, Satya?
Yes, sir. The hazard ratio is less than 1. So it is
Yeah.
no, it is not crossing 1, so it is statistically significant.
Excellent. So if it is less than 1 means it is beneficial. That means there is less death, MI, and stroke in our treatment arm compared to the placebo arm. All right. So, and since it is not crossing 1 here, it is statistically significant. That's what it means. And here is the Kaplan-Meier curve. Okay. So we took, this is for the second co-primary outcome. Don't worry about it. This is second co-primary outcome, 0.72 that you see here. This 0.72 is, where is it? Oh, here. Okay. I had to go roundabout here. 0.72, same thing. 0.71, 0.72 doesn't make big difference. There is a one other outcome, which was resuscitated cardiac arrest and heart failure was added to that. And here 0.72 means it's a 28% reduction in death, MI, stroke, cardiac arrest, heart failure, etc. And this is also statistically significant. All right. Okay, let's go to the next question. What if I cannot blind the treatments? Now here, when we gave placebo, it was blinded. It's very easy. One white tablet, active drug, another white tablet, placebo. That's easy to manufacture. What if I cannot blind the treatment? How do I evaluate health systems intervention? What is health systems intervention? The whole hospital is, some interventions happen in that hospital. There is some health education, or there is some discounted treatments or whatever. Okay, so health systems intervention. And when we are doing that, how do we avoid contamination in policy interventions? Contamination means one intervention going to the placebo arm. Sorry, there's no placebo here. In the control arm, we call it control. So the solution is to test intervention on entire groups and keep the groups apart, right? This is called a cluster randomized control trial, to compare interventions allocated to entire groups or to a cluster, not just to individuals. All along, we were seeing individuals. To evaluate complex interventions. So we use it in health services research. Now, what are the groups? The groups can be communities, could be villages, could be schools, could be workplaces, could be certain hospitals, or could be private clinics of certain doctors. Okay, so these can all be clusters, and what we do is first we assemble the cluster. Okay, here is a simple diagram here. So we have cluster, where is cluster 1, cluster 2, cluster 3, cluster 4, and cluster 5. And each of the cluster is slightly different. Can you see? Here there are 3 dark browns, 1 dark brown, 1 dark brown, 2 light brown, and different kinds of people, because each cluster is also somewhat variable. People are not exactly the same everywhere, but there is some uniformity as well. Okay. So now the entire cluster is randomized. Can you see? C1, 1, 4, and 6 have been randomized to intervention. The other 3, 2, 5, and 3 are randomized to control. Now we conduct the study and we evaluate the individual patients now for outcomes. Let me give an example of this trial that we did. This is to improve the use of oral anticoagulants in atrial fibrillation. We did an international cluster randomized trial, and these are some of my friends from different places. He's from Romania, he's from Brazil, she's from Argentina, this is from China, and this is from, he's a statistician who works. So we were all a group of people. We got together, and he was our senior colleague, Christopher Granger from Duke University in the US. We did this study. Okay. And so this was a quality improvement study. We wanted to encourage people to use oral anticoagulants correctly. So there was health education, there was guidelines, and all of that we did. Okay. And so, as I said, see, quality improvement and educational intervention. We did that. We did this in 48 institutions in 5 countries. 48 institutions in 5 countries. And here are our results. We wanted to improve the use of oral anticoagulant treatment. So this is intervention group, this is control group, and at the end of 12 months, you see this difference. At the end of 12 months, you see this difference. And we have now an adjusted odds ratio of 3.28. Okay, this is for the use of oral anticoagulant. That means in the intervention arm, there's a 128% improvement in the use of oral anticoagulants, and it is highly statistically significant. And this is the confidence interval if you want to see. Right? That's what we found. Okay, so we can use, this is for the risk of stroke also, we got this difference at the end of 1 year. So it not only improved the use of oral anticoagulants, we also reduce strokes. So this is red one is control. Sorry, I went to the wrong page. Sorry, red one is control and blue one is intervention. So in the intervention arm, there was reduced number of strokes. Okay, next, this is a dream for many people who are doing trials. Can I make trials more efficient, more ethical, and lower cost? So for that, and I want to get results faster, right? So the solution is to keep making changes to the trial based on the results. This is not protocol amendment. This is, as we are getting results, we analyze it and we're going to say we want to improve the efficiency. So this is called adaptive trial designs, and I'm going to give you an example from urology in the next few minutes with an adaptive trial design. So when results, we keep collecting results, we use that, and based on predetermined rules, okay, we modify the trial scores. The rules are already written and kept. Okay, here is it. I've written it here. Pre-specified rules. You don't make the rules as you go along. If this happens, this must. So it's like an algorithm is already written and kept before we start. Okay, adaptive designs can be done according to, at all phases. So, sorry, that is a, okay, here. Sorry, there is some, okay. So there was a little repetition there. Okay, so this is a traditional fixed sample design. We design the study, we conduct it, we analyze it. Sometimes the treatments work, sometimes the treatments don't work. Treatments don't work sometimes because maybe the trial design was not good enough. We didn't have sufficient patients, or follow-up was not good, assessment was not good, or the treatment itself doesn't work. However, now in an adaptive design, what we do is we design, we conduct, then what we do is we review. Okay, we review and then we adapt, we make some modifications, then we conduct it again. And this we can do a few times. We can go round and round in circles for a few times. We're not going around in circles, but we are making changes as we go along. Then we analyze and we share the results. So to be able to do this, you need to have very experienced clinical trialists and very good statisticians. And that is a bit of a disadvantage to get these kind of people. But if you're able to do adaptive trials, it is fantastic. Now, there are many different types of adaptive trials. Whole books have been written about it, lots and lots. I'll just show you the names. I will not even read it out. Just read this for yourself. I'll finish my tea in the meantime. There is one more slide. Just read through this as well. Okay. So let me go back to the first one. So what is the meaning? I mean, each of this we can take a whole lecture on. There's so much material on it. But this is a biomarker adaptive trial. So the PSA that you do is a biomarker. It's a marker of you all are the champions in that. Okay, so of prostate cancer, and then based on and then you're giving chemotherapy, let us say. So based on PSA levels, you keep on adjusting the dose of your chemotherapy agent. All right, so you keep on increasing, and of course, if you increase too much, then you have side effects, right? Okay, then you have adaptive randomization. The number of patients you want to put in this arm versus that arm, you can modify. You can modify the doses. Usually we do phase 1 trial, phase 2, and then we do phase 3, but you can do what is known as seamless phase 1 and 2. Together you design it. You don't wait. It's not sequential. Together you design it one after the other. You can do seamless phase 2 and 3 together as well. Okay, combined selection. Then you have continual reassessment, group sequential. These are all a little complicated. I will show you multi-arm, multi-stage, and if possible, a population enrichment design. I'll show you the concept. Okay, so let's look at master protocols as a concept. What is a master protocol? Now you have multiple treatments and you have multiple conditions, and mainly these things are done in oncology, and you will see this in your urology journals as well for different cancers, uro-oncology that you folks deal with. So this is what it means. So the next time you're reading a journal article, it makes that much more sense for you. Master protocol means you have one protocol and you can do many trials. Okay, so just like maybe on a Sunday morning, you wake up and with your family you say, okay, let's go out for breakfast, and along the way we'll do some shopping, and then after shopping we'll have we will meet a friend and we'll come back. So you take the car out once, you're doing 3 things and coming back. Many times we do that, right? Instead of going for breakfast, coming back, then going for shopping, coming back, then going meeting a friend and coming back, right? And particularly with kind of traffic that we have anywhere in the country these days, especially in Bangalore, it's better to go. Sunday morning is a good time to drive around in Bangalore. Okay, so one protocol, many trials. Okay, there may be many patients. You can have different patients with different conditions, and you can have a shared control group. Okay, I'll show you a diagram of that shortly. So here are types of master protocols. You have basket trials. You have a single investigational product in different indication. You take one chemotherapeutic agent, they can be used in different cancers, right? So you write a master protocol for that. Basket is one investigation, multiple indication. Now you have the opposite of that called umbrella trial. Okay. Now you have many drugs in one indication. Okay, so let's say prostate cancer, you want to do a monoclonal, you want to do a chemotherapeutic agent, you want to do maybe one other drug, okay, but you'll have a common control. So that is a possibility, umbrella trials. Then you have platform trials. Platform trials means multiple treatments, one indication, and you do that in multiple stages or in a perpetual manner. The Stampede trial is a good example. So all of you should be familiar with the Stampede trial. India also participated in that. So let me give an example of a MAMS trial. It's a platform RCT. MAMS is multi-arm, multi-stage trial. So this is to speed up the evaluation of new therapies. You're not doing one trial after the time, one trial, one trial, one trial. You're doing multiple things at the same time. Many treatments compared against a common control. So you can do pairwise comparison in several stages. That is MAMS. Okay. I'll skip that part and I'll show you this. This is the traditional approach. What do we do? Phase 2. You have treatment 1, treatment 2, treatment 3, treatment 4. You are evaluating it. Okay. So phase 2. In a phase 3, what do you do? So now treatment 2 did not work. So you're not evaluating that in the next phase. So you're doing a separate trial. Treatment 1 compared to control. Treatment 3 compared to control. Treatment 4 compared to control. 3 different trials. Okay. However, if you do MAMS, this is what it is. One control. Got it? One control. Treatment 1, we go continuously. Treatment 2 did not work, you stop here. Treatment 3, you go up to here and you stop. Treatment 4, you go all the way. You see the efficiency now? So treatment 1 compared to control, treatment 4 compared to control. So you can do that as well. So you have, this is, okay, I don't overload you. I'll do this as the last one. Sequential multiple assignment randomized trial called SMART. Okay, patients are treated using a sequential and an individually tailored approach. You also have something known as dynamic treatment regimen. Okay, there are pre-specified decision rules. If this happens, do this. If that happens, do this. This happens, do this. It's all written and kept, and you follow that. Okay, so there'll be sequences of treatment decisions. You increase the dose up to here and stop. After that, you stop giving the drug, you give another drug. Rules are written and kept, so you have multiple things that you can do. Okay. The SMART treatment along with DTR, or that is for the dynamic treatment regimen, you can do that in addition to standard multi-arm trials as well. Okay. So let me give you this example of the Stampede trial. Are you familiar with the Stampede trial? Anybody?
Yes, sir. Yes, sir.
Come on, Satya, tell, what do you know about Stampede trial? It's there. The whole story is there. This is a little bit old. It's about 2 years old, this diagram, but more progress has happened.
Yes, sir. This is for metastatic CA prostate, sir. For hormone sensitive,
Right.
whether the androgen deprivation therapy
Deprivation.
along
Yeah,
with
80.
abiraterone or docetaxel therapy, everything is compared in this study, sir.
Excellent, excellent. Okay, very good. See, when did the study start? Started in 2006. And how many different studies? Okay, so you have ADT here. So you have zoledronic acid here, docetaxel here, celecoxib here. Okay, they tried that as well. It's a painkiller, right? And then you have combination drugs. Okay, so how many trial arms? You went down to this is 10, 11, 12 trial arms. Okay, and then they did a series of studies, let us say up to here. Then they stopped this trial here, results were declared. Stopped this trial here, results were declared. Now, patients in this arm, they shifted over to another one. Okay, with or without docetaxel. Okay, and it continued on up to 2021. Okay, now after that, they started using, sorry. Okay, there is a little description of this in the next one. Then they started using other drugs as well, metformin, and I'm not sure what E2 is. E2 is here, transdermal estrogens. Okay, I missed that. Okay, so Stampede trial is a multi-group, multi-stage platform protocol. Okay, they investigated additional therapy at the time of inception of primary ADT in men, along with newly diagnosed, locally advanced, or metastatic. So multiple types of prostatic cancer as well. Okay, and those who relapsed and those who had poor prognostic factors. So they set up like one enterprise, like Starship Enterprise, or multiple things that they had. Okay, and they did multiple studies. So one of the results, which was published a few years ago, about 8 years ago, in the New England Journal, was abiraterone for prostate cancer, not treated with hormone therapy. So they assessed abiraterone along with prednisolone, right? So who are these people who are on long-term ADT? Okay, they used a multi-group, multi-stage trial design, right? So, and this is one of the trials that was published. So like this, they had many trials that were published. So what are we talking about? Platform trial. So this is what I wanted to tell you. I gave you over 2 days, I gave you an overview of trials. So let me kind of summarize this even before it comes up here. We started off with basic concepts. Why to do trials? What is randomization? What is blinding? Why to blind? What is allocation concealment? How to do that? What are the different types of randomization? And most importantly, what does randomization achieve for you? Purpose of randomization. That means we get groups that are similar in all ways except the treatment, and you are able to evaluate those treatments, right? Then we did different designs, parallel group design, and then if you can't use a non-inferiority, superiority, or equivalence, we have that. Then we have a crossover design, and if you want to do more than one treatment, we can do a factorial design, 2 by 2 factorial tests, 2 different drugs, and you have 4 different combinations and the different ways to analyze that, I told you. Then I told you, if you can't blind treatments, what to do, right? And if you want to do health systems intervention, sometimes you want to, make some changes in your surgical protocols, right? So so suppose you have 20 OTs in your institution, you can randomize those OTs. 10 here and 10 here, the whole OT. And all the patients going to these OTs, different OTs, and they'll have different interventions. So that is a cluster randomized trial. Or the entire institution can be a cluster. And these are very important studies to do to improve patient outcomes. Then finally, I told you about adaptive trials. And each adaptive trial, we can take a 2-hour seminar. There are so many nuances to it, but I gave you a flavor, and many of these will be in your urology journals. So please, when you read that up, you will find that these are making more sense. So let me conclude. RCT is a powerful tool. It's the gold standard to evaluate interventions. Don't believe any other design which talks to you about treatments. They'll do all kinds of things. Sometimes those pharma companies, what they do is they do real world evidence studies, something like that they'll do. And then tell one treatment is better than the other. There are little issues with that, which we are not discussing today. Okay, randomization, what does it achieve? Ensures a balance of prognosis. Concealment of allocation and blinding, as I told you, are important design considerations, and they reduce bias, and you're able to evaluate your treatments. Continuing, non-inferiority trials are becoming increasingly common these days. Why? Because we have treatments pretty much for all conditions. So our new treatment is tested or evaluated against the best available treatment. And I gave you all that details. Factorial designs have several advantages. Cluster randomized trials for health systems research, adaptive and other novel designs bring in efficiency in terms of time, money, and even patient safety. Okay, right? There are unique challenges in cancer trials, and we need to, and there are several design options to bring in efficiency, and you see that in your urology studies. All right, so that's what I wanted to share with you today. I'll be happy to take questions from you or any comments that you may have.
Arvind sir?
Yes, please, Dr. Chandraman, go ahead.
Arvind sir?
As Dr. DENIS yesterday only said that it is always good to be a bit confused. So today also I am a bit confused, but I just wanted to ask is that I saw the 12-arm trial for metastatic CA prostate. So they stopped the celecoxib arm, which was the H arm in that. So I was just wondering, in these adaptive trials, is there a chance wherein there might be some amount of bias that creeps in when you stop something? And how do they overcome that thing?
Sorry, I was on mute. There is less likelihood of any bias. See, bias comes in when you make modifications to your advantage. Okay. Now here, any adaptation that is made, not modification, any adaptation that is made before the trial starts, or the rules are written before the trial starts. Okay. And these rules are based upon best available evidence at that time and the design considerations for that adaptive design. So I can fairly confidently tell you there are no biases here. However, it is quite difficult to understand these trials and actually conduct them and do it. But as I told you in the last line in that adaptive trial, it brings in efficiency in terms of time, in terms of even efficacy, as well as it's more ethical and less harmful to patients. So unlikely that bias would have come in there.
Otherwise, sir, as usual, it was very informative. Dr. Chandramohan, your comments?
Nothing, sir. I'm observing, I'm watching, I'm trying to learn. But I am understanding as the later part of the discussion, a little bit confusion will be there. But much better than before, like what is randomized control trial or randomization. Why they are not saying superior, why non-inferior? The curves falling on the right side, left side, going beyond the dotted line, how they became very inferior. So these words I'm understanding much better. Probably if I put an article and then compare, I will understand better. Every time when he's explaining with an article, like warfare in all these things, up to one comparison I was okay, but multiple comparisons it become difficult to understand. Warfare in 150 mg, that study explained very clearly how it is conducted, and at least the conference interval and less than one, the importance of the significance I could understand. To that level, I could understand today.
Right. Okay. Good. So now, in the coming week, I'm in Geneva the whole week. So we won't have the session. I think I informed you sometime back, itself, Dr. Chandramohan. So
Right.
our next session will be 29th and 30th of May, not 22nd and 23rd, 29th and 30th. And with that, we will start our session on
Start.
data management and biostatistics. So we
Understand.
will start with, types of data, how to look at whether these data are normal or not, what are parametric tests, what are non-parametric tests. And I have very simple examples, and I will not go into mathematics and complex calculations, which no doctor likes, even I don't like. But we will look into concepts, okay, and how to interpret them. What are the, so say for example, the t-test that we do so commonly. What is the concept behind a t-test? Okay, so it is for, so we are comparing two means, mean of this group versus mean of this group. Let's say PSA in this group versus PSA in this. What is mean PSA out of these 500 people here? What is mean PSA here? How do we compare the two? Okay, so the concept there is the difference between signal and noise. And I will explain what that is. Like that we will do. And when we cannot do parametric tests, when we have to do non-parametric tests, which are the commonest non-parametric tests, such as, chi-square test, Wilcoxon sign rank test, Friedman's test, and all of that we will do we will take a 1 week break now because I'm traveling. I have a meeting at the WHO and World Heart Federation meetings. So we'll do that, and I will see you week after that. And Dr. Chandramohan, we can discuss along with Dr. Ginil about the plans at Cochin. My calendar is getting quite busy with travels both outside and within the country, but then we'll work something out for Cochin.
Right.
Okay.
Okay, sir.
Okay. Good night, everyone, and have a nice weekend. And we pray for our soldiers and everybody on both sides. Everybody's human. Nobody should die.